Hello friends, myself Dr. Neil. Let us learn ECG in easiest way, okay? So as you see, a current is flow from SA node to AV node, from AV node to bundle of his to Purkinje to ventricular muscle. Now in ECG, one small and there is a one large box. One large box which contain a 5 small box and one small box which is approximate 0.04 second duration. Now in ECG there is a P, Q, R, S and T wave. Here P wave which indicate atrial depolarization, Q, R, S segment ventricular depolarization and ST segment which is a ventricular repolarization. P wave, there is a P segment which is about a 2.5 small box, PR segment 2.5, QRS 2.5 and ST segment 7.5. So you can remember 2.5, 2.5, 2.5, total 7.5. Okay, by that way you remember it. And total which is a QT segment which contain a 10 small box. So now first we focus on rhythm. We check rhythm by RR interval. If RR interval is same, then rhythm is regular. If interval is not same, then the rhythm is irregular. Irregular rhythm which is seen in atrial fibrillation. After checking rhythm, we check heart rate. By formula 300 upon number of large box in between RR interval or 1500 upon number of small box in between RR interval. After checking rhythm and heart rate, if heart rate is more than 100, then we again check a rhythm. If rhythm is irregular and P wave is absent, then probably it atrial fibrillation. If rhythm is regular, then check QRS. If QRS is normal, then supraventricular tachycardia, means there is a pathology which is above a AV node. If rhythm is regular but here QRS is prolonged, then pathology is related to the ventricles and it is probably ventricular tachycardia. Now we focus on P wave. In lead 2 there is a tall P wave which indicates there is a right atrial enlargement, and bifid or there is a wide P wave which indicate left atrial enlargement, and absence of P wave which is atrial fibrillation. Now after P wave we focus on PR interval. The normal PR interval is 0.12 to 0.20 second, 3 to 5 small box. If PR interval is more than 0.20, means there is a more than one large box, then probably a heart block. And PR interval is less than 0.10, less than 0.12, then it may be a WPW syndrome. In WPW there is a delta wave is seen. What exactly is seen? In WPW there is a abnormal pathway between the atria and ventricles. So current is flow from atria to ventricles, and here there is a AV nodal delay which is a bypass. Now in after P and PR interval we focus on QRS. Normal QRS less than 0.12 second, means there is a less than 3 small box. If QRS is more than 0.12, then it is maybe RBBB or LBBB, means there is a right bundle branch block or left bundle branch block. Okay, in right bundle branch block there is a marrow pattern, means there is a M pattern in V1 and W pattern in V6, while in LBBB there is a W pattern in V1 and M pattern in V6. If you don't recall this formula, then easiest way to see a T wave inversion. If T wave inversion in lead V1 means there is a etiology is related to the right side, and if T wave inversion which is seen in lead V6 means there is etiology is towards left side. Okay, now after QRS we focus on QT interval. The normal QT, which is a 10 small box, the prolonged QT more than 0.44 second, okay, which is seen in hypokalemia, hypocalcemia, and there is a class 1A anti-arrhythmic drug. Normally there is a class 1 anti-arrhythmic which block sodium and potassium channel. The black one is normal, the blue one which indicates that is after administering a class 1 anti-arrhythmic drugs, you can see a downwards slope, means there is a sodium channel block, and there is a prolonged horizontal line, there is a potassium channel block. And the short QT, which is a less than 0.36 second, which is seen in hypercalcemia, and there is a class 1B drug. This class 1B drug which open a potassium channel. So as you see, there is opening of potassium channel, there is a horizontal line which is not prolonged as much as than normal. Okay, and after QT interval we focus on T wave. If T wave is tall, then there is a hyperkalemia, and if there is a U wave is seen, then hypokalemia. Okay, so now in MI, which changes are seen? First, there is within a minute tall T wave. After minutes to hour ST segment elevation, as you see, T wave inversion which is seen in days, okay, and Q waves which is a days and weeks, there is a Q wave is seen which is a pathological Q wave. Now in which lead we see V1 and V2 lead, there is these changes which indicates there is a septal wall MI, V3 V4 anterior wall, V5 V6 lateral wall MI, and for inferior wall we see a lead 2, 3 and AVF. Okay, now in hyperkalemia what we see, there is a PR interval which is a prolonged, and there is a T wave increase in size. Okay, while in hypokalemia a PR interval is prolonged, QT interval is prolonged, and U wave is seen. Okay, so by that way we differentiate hyperkalemia and hypokalemia. Now the other is ECG finding which is important, like in digoxin toxicity. As you see, there is a there is a QRS TOK. So there is a ST segment, there is a depression which indicates digoxin toxicity. Here there is a reverse hockey stick sign which is a seen. Okay, while in hypothermia, Osborne wave which is a seen Osborne wave which is a seen in MI and pericarditis. How we differentiate? In MI you see a ST segment elevation, but here we compare with this ECG finding, we can see there is a like a sadness type of feeling. Okay, there is a changes, and in pericarditis we see there is a smiley face. Okay, and also there is a PR segment which is a depression which is seen in pericarditis. So in MI there is a finding, there is a ST elevation finding like sadness of faces, and in pericarditis there is a ST segment elevation which is seen like a smiling face. Okay, and also in MI there is a reciprocal changes like ST segment depression which is seen in opposite lead, while in pericarditis there is no reciprocal changes, only there is a PR segment depression which is seen. Okay, as you see, while in pulmonary embolism S1, Q3 and T3 which is a finding is seen, means there is a deep S in lead V1 and deep Q and T in lead 3. Okay, as you see in lead 1 there is a S wave which is a deep, and in lead 3 there is a Q and T wave which are deepen. Okay, so in cardiac tamponade there is a electrical alterance which is a seen, means as you see there is a RR interval which is the same, but here there is a R wave, peak R wave, then smaller in size, then again increase in size, then again smaller. Okay, so there is electrical alterance. While in atrial flutter, as you see there is a RR interval is a same, but here there is a sawtooth sign which is a seen. And the most important topic, there is a heart block. Okay, so how we there is a differentiate heart block in type 1, 2 and 3 by there is RR interval. If RR interval which is a constant, then maybe a first or third. If RR interval which is not constant, then second. Okay, now in first there is RR interval is constant, here there is a PR is also constant. Okay, while in third there is a PR interval is not constant. While in second degree heart block, two types, Mobitz 1 and Mobitz 2. In Mobitz 1 PR interval which is a gradually increase in size, while in Mobitz 2 a PR interval is constant. So by that way you see a RR interval which is a constant, there is a type 1 or 3. In 1 there is a PR is also constant, while in type 3 there is a PR is not constant. If RR is not constant, then Mobitz 1 or 2. In Mobitz 1 there is a PR segment which is a gradually increase in size. Okay, while in Mobitz 2 there is a PR segment is constant. Hope guys this video is helpful to you. Thank you so much.